Okay, my name is Heun. I'm a consultant psychiatrist and editor of Global Psychiatry Archives, and today I wanted to talk about the epidemiology of schizophrenia. So first about the incidence. Incidence means the number of cases which appear in a specific amount of time. So usually the incidence is quite similar all over the world, and it's usually around 50 new cases per 100,000 per year. Usually it's the same in females and males, and usually it's also that males have a slightly earlier onset than females. So it means that let's say the age of onset is 23 with the average in males and 26 in females. And usually males have more severe illnesses. That's not totally clear why that is, but it's a fact which has been overall observed quite frequently. There have been changes in the incidence, that's the number of cases per year, over a specific number of population, and that might have to do something with different ways of diagnosing mental health disorders. So it's not totally clear whether there's a major change, and it's also very difficult how treatment influences the prevalence, because if you start treating people very early, there have been quite a few early treatment programs or prevention programs, and if you treat very early and the patient doesn't get the disease, then you wouldn't see it. So sometimes, people who have been treated at risk, then they might not develop the full-blown disease, and then maybe something else is diagnosed, like schizoaffective disorder. The other problem is that the culture of diagnosing is very important. Some people see that affective disorders, let's say depression, is more prevalent or more important than delusions. So they would call something where paranoia and depression is at the same time. They would call it a schizoaffective disorder. Some might call it delusional depression or psychotic depression, or others would say that depression is part of schizophrenia as well. So it depends very much on how a patient talks a story, whether any of these diseases is diagnosed. However, on the long term, it's usually it's getting clearer and clearer, especially if you have initially symptoms with depression and paranoia, and over the years, paranoia becomes more and more important. The other thing is what is very important for the differential diagnosis, the fact that their negative symptoms are more prevalent in people who have schizophrenia than in affective disorders. Anyway, so the prevalence means a number of people seen in a specific time and area. So usually we have a lifetime prevalence, which means of people getting the schizophrenia any one time in their life. That's between 15 and 19 per 100 population. So it's more or less 1 to 2%. The point prevalence is less, so that's a time when you say any one time in the population there are about 5 people who currently, 5 out of 1,000 people who currently have a psychotic illness. Usually, again, there's some differences between countries, but when you look and try to train people in a way that they use their diagnostic criteria very identically, then the prevalence is not much of a difference. Fertility is usually reduced in people, in men and women with schizophrenia. However, in many cases, the fertility disadvantage is much worse for men than for women. That means men who have schizophrenia find it much more difficult to find a partner, whereas women who also have the age of onset slightly later find it easier to have a partner. Usually the schizophrenia leads to an increase of mortality, and some people say it's a 20% reduction in life expectancy, which would be translated into a shorter life of 20 to 25 years. And that the main cause for this shortened life is suicide, but there are also other physical health problems which might contribute that. But suicide is the big issue and accounts to 10 to 30% of all deaths in schizophrenia. And usually it's not in people who have lived schizophrenia for a long term, with schizophrenia for a long time, but very often people very early who are very overwhelmed with hearing voices. However, I can remember a patient myself who had been long-term treated with different types of antipsychotics, very unsuccessful, and over the years everything had been tried, but eventually we could give him some medication which was amisulpride, which made him better, but then he realized how much of his life he had lost. He was already 60 and then killed himself, even though he, from the symptoms, was slightly better. Right, people with schizophrenia have many medical problems, which is communicable diseases, HIV, hepatitis, tuberculosis, epilepsy. Diabetes is a big problem, especially on clozapine medication. They very often have heart problems and arteriosclerosis. Other people say that other very rare disorders like metachromatic leukodystrophy, porphyria, celiac disease, or other dysmorphic features might co-occur with schizophrenia. Possibly these rare diseases affect the brain, and when the brain is affected, psychotic symptoms are more common. Many people with schizophrenia usually take drugs. Very often they take drugs to calm them down, so they treat themselves. They might take cannabis, stimulants. Usually they smoke a lot, which again leads to arteriosclerosis and ischemic heart disease. The other thing is that cannabis can also cause psychotic symptoms and trigger schizophrenic illness. So cannabis is used by people who have schizophrenia just to treat their symptoms, calm them down, but on the other hand, it can also lead to psychotic symptoms and triggering of a psychotic illness, schizophrenia. Coming to another point of the epidemiology is the inheritance, and it's said that genetic factors account for a large number of people having schizophrenia. The estimates of heritability range around 70%, and that means that lots of people have schizophrenia as a background of their genes. However, even identical twins only have 50% of the same risk as the affected siblings. So that means if one sibling has schizophrenia, the risk for the other ones is, say, 45%. If you have one sibling who has not identical twins, but one sibling who you usually would share 50% of the genes with, then you would have a 15% co-morbidity. Co-morbidity means both have schizophrenia. If both parents are ill, having schizophrenia, the risk is 40%. If one parent is ill, you would expect a risk of 12 to 15%, more or less the same as if you have an affected siblings. If one grandparent is ill, the risk is 6%, and if you don't have any affected relatives, then it's 1% or 0.5% to 1%. There have been, I think, nearly 1,000 genes which have been individually associated with an increased risk of schizophrenia. They're different genes, more or less, in the metabolism of neurotransmitters. Glutamatergic neurotransmission is affected, genes which affect synaptic plasticity, the major histocompatibility complex genes have been seen changed in people with schizophrenia. But usually what you have to see is that the amount of individual contribution is quite limited. So usually one would expect to have hundreds of genes which are more or less prevalent or rare in the population, that hundreds would contribute to increasing the risk of schizophrenia. There are other environmental factors which might contribute to the risk of schizophrenia. These are complications of pregnancy, delivery, and during the early neonatal period. That might be a problem of cause and consequence, that people who have a brain problem or a problem in the development of the brain not only have complications of pregnancy or in the neonatal period, but then also have a risk of schizophrenia. So, or the pregnancy complications might affect the brain and then lead to schizophrenia. Usually, and this in the same sense, delayed walking or other neurodevelopmental difficulties can increase the risk of schizophrenia. Again, not totally clear what's cause and consequence, or if both symptoms or both disorders are the consequence of one other cause. Right. Usually, if you have early social contact, so you already have problems in your youth and disturbed childhood behavior, the risk is increased again. Malnutrition in the pregnancy, so severe maternal malnutrition might affect the development of schizophrenia. Influenza during pregnancy or winter birth may increase the risk of schizophrenia. The latter maybe not a major factor. Then use of cannabis during adolescence and also during pregnancy. I think most psychiatrists would say that if we wouldn't have cannabis, the number of people with schizophrenia goes down. However, very often it's not totally clear whether it is drug-induced psychosis or schizophrenia, because you can't know what would have happened if the patient hadn't taken the drugs, if they develop a psychotic symptoms. Right, I hope that's it for the epidemiology of schizophrenia for today, and I hope you are interested in stuff like this and subscribe to our channel if you want to. You're welcome, and have a nice evening.